Hello, and welcome back to Deconstructing Unconscious Bias in Behavioral Healthcare, brought to you by the Addiction, Mental Health, and Prevention Technology Transfer Centers of HHS Region 2. This is Session 3, Dismantling Bias and Building Equity. First, I'd like to introduce Ms. Diana Padilla, who is a research project manager at the New York State Psychiatric Institute at Columbia University. Ms. Padilla has over 22 years of public health service, including curriculum development, the conduct of evaluation of substance use disorder treatment programs and problem solving courts, engagement in chronic disease research and prevention, and the provision of classroom instruction to behavioral health professionals, prevention specialists, and drug court practitioners on behavioral health and recovery support practices. Next, I'd like to introduce you to Dr. Natalie Bembry, who is the Assistant Director of Student Affairs, the Camden Campus Coordinator at the Rutgers University School of Social Work. She has over 20 years of experience in the field of social work with various populations and settings, such as dual diagnosis, developmental disabilities, children and families, juvenile justice, and education. She teaches in both the graduate and undergraduate programs at Rutgers University and serves as an adjunct and online course developer in the Department of Social Work at St. Joseph's College of Maine and at Delaware State University. Dr. Bembry is passionate about education and has spent the last few years sharing her research and zeal of cultural humility to all disciplines. She emphasizes the tenets of cultural humility, specifically focusing on self-reflection and critique and the impact it has on our interactions with others, thus creating a natural transition and motivation towards openness and lifelong learning.
Kelly, for opening up for us. So these topics have been focused on on a wealth of different. There's been a wealth of information focused on unconscious bias. This is just one of many factors that contribute to inequities in behavioral health care for racial and ethnic communities. And so the TTCs are brought together to be able to try to support all your professionals in the addiction and prevention and mental health fields. And so we've had a very healthy response. And I just want to let you know, if you haven't realized it already, or if you're just new to this, is that the information tends to build on each other. It's a really nice way to make sure that to ensure that we understand how these concepts actually do play out and work out in our settings. So today we're at the third session. We want to talk about how to dismantle bias and build equity. Well, we have provided you information on how to identify bias and how to mitigate its impact. And so right now, there are certain things that we can do other than bias reducing strategies. There's other opportunities that we have available to us. So we will present on, Dr. Membry will present our culture of humility, and I'll follow up with the culturally and linguistically appropriate services standards. And we'll be able to give you more information as we go along. So I wanted to take the opportunity to welcome everyone and also to thank Dr. Membry for being here with us. Let me send it over to her.
So good afternoon, everyone, and welcome and thank you. It is my pleasure and honor to be here with you all today. Okay, I tried it. In full disclosure, I will be saying y'all for the rest of this presentation. I really try to bring it down, but yeah, I'm a Midwesterner and that's just what we say. So that's what we do. So as I listened to the previous information that Diana shared regarding implicit bias and what you've discussed over the previous sessions, I was excited to see the connections and continuity that this presentation would bring. So bias in any form impacts who we are and the work that we do. And in my short time with you, I'm going to share a couple of conceptual and practical tools that will assist with challenging our bias and moving us along the continuum of cultural humility. So in my first tool that I want to share with you is the ladder of inference. And I like to see everybody, and I know we can't see everyone, so y'all bear with me as I go through it because I'm used to that, but it's fine. We're going to work with this. But in my first tool, I want to talk about the ladder of inference. And this may be something that is familiar to you all, and which is great. and you can also apply it to any part of it. The tool was actually created in about 1970 by Chris Argyris, who was a Harvard business professor, and it was really a decision-making tool. And so using this as our tool to look at cultural humility, you'll see the interesting connections between the two. So first, I'm going to start at the bottom of the ladder. The bottom ladder, the rungs down here, where it starts with data and observation. And when you look at this, our data begins with what's presented to us, what we observe in the world. In doing that, we start moving up this ladder. So now we're looking at some of these facts that are based on our convictions or our prior experiences. And then when we get to these um, meanings, we start to add meanings. It's based on interpretation, and we give personal meanings to that. And then moving on to assumptions. Now, based on my observations, I make these assumptions and I draw conclusions on my previous or prior beliefs. And then those beliefs then become the interpreted facts that I use, and then I take action based on that belief. So let me give you a practical example, because sometimes it's a little bit harder when you kind of just go theoretical, but practical example. So prior to coming to Rutgers, I worked as a child welfare trainer, and I spent a lot of time driving on the New Jersey Turnpike. So if you're familiar with New Jersey Turnpike, it was the devil before they opened 6 lanes. So 3 lanes on the Turnpike, it was, you could spend, my commute was about 55 miles one way up to New Brunswick, and you could spend at least 2 hours driving the Turnpike one way if one jackknife tractor trailer happened, if one accident happened. You could spend that time. So let me preface this by, this is a no judgment zone, right? So we're all talking, we're going to be vulnerable, and we're sharing different parts of ourselves. So I'm going to tell y'all about my ladder of inference training here, or my actual walk through the ladder. So driving this turnpike, it was torture every day for me. But it was never a day that as I was driving, there was always one person in the fast lane holding up traffic. Always. It was inevitable. And I'm sure y'all seen this in your own driving too. So one person holding up traffic. Every day as I'm driving this turnpike, I see each day there's one person who stays in the fast lane. Now I don't have road rage. I'm gonna tell y'all that, well, maybe a little bit, because I lived in New Jersey for about almost 30 years, so maybe a little bit of road rage. But the problem was every time I pulled up, and I would see, and when I finally was able to maneuver around and get to the car who was holding up traffic, when I looked over, remember we said no judgment, y'all. I looked over and it was always a Pennsylvania license plate. So I took this observation every day as I'm driving the turnpike, and I see it's a Pennsylvania a plate, a Pennsylvania plate. And so I just said, this is crazy. What is going on in Pennsylvania that folks to stay in the fast lane and hold up traffic? So as I was going through this, you could see my observable data was there, right? I'm driving every day and I continually see the Pennsylvania plate holding up traffic. So then what did I do? I start to add these interpretations, right? So I started adding meaning to it. So now it's definitely, and it could be even as I'm driving, and maybe when I got to the front of the line and got to see the car, it might not have been a Pennsylvania plate, right? Maybe it was a New Jersey plate. What was my first thought? Transplant. They came from Pennsylvania because they're holding up traffic. So I made these assumptions and these conclusions, and now my actions and beliefs are really focused on this. Every time I see somebody holding up traffic, it was someone from Pennsylvania. So with this, all these assumptions that I made, and even people that I knew who were from Pennsylvania, like from Philadelphia, if I see them driving on the street, we honk and wave at each other, I'm already still looking at them twice. So I'm like, I know you can really hold up traffic somewhere because that's what I see, right? So I use this lighthearted example, but it's factual because you can see how easy it is for our bias to guide our actions. But think about the work interactions with your clients, your colleagues, anyone. I mean, really, it could be any person. A split second of bias can certainly drive us into actions that would compromise our relationships with others. Ultimately, our beliefs will influence how we treat others. Why? Because how I see you is how I am with you. So as I thought about this example, and it was one time I told this example in a training, and someone said, that was you. I said, oh my gosh, they saw me on the road because I probably was like, get out of the road, get off the lane, blah, blah, blah. So they pointed out, like, I saw you. I was like, oh my God, okay. Well, I'll fix that for another time. So with this, how do we counter this? How do we do this work? And the first thing we have to do is understand the process of change. I like using Prochaska and DiClemente, which I know is probably pretty familiar with you all. Whenever we're talking about change, right, we're thinking about change is not easy, right? So when we're thinking about this, it's not going to be an easy task to make a change. And when someone tells you to make a change, most times we are not really going to agree to that, right? So when I think about this and I talk about first I want you to think for really quickly. Think about a time when someone told you you had to make a change. How did you feel when they told you? What feelings came about when they told you to make a change? And then what thoughts came to your mind when they told you it was time to make this change? So I would say sometimes or many times when someone tells us to do something, we instantly become defensive because our human nature does not like to take orders from someone else. But I am telling you today that we all need to make changes regarding our bias. Most times when I say this to anyone, it is inevitable that one, two, three, four, maybe 50 people will say, it's not, I don't have a problem. So I really don't need to make a change because I don't have any problems. But when you think about it, we do have some things that we need to look at, whether our bias has an issue with race, with gender identity, any of the isms, we have to really start to look at this. So if I'm in the group that says I don't have a problem, that I don't really need to look at this, then we are in pre-contemplation. We're in that phase where these thoughts, they may cause us to commit a microaggression, whether it's intentional or unintentional, that we don't think we should have, that we don't think a person should have a problem with what we said. And that's where you'll commonly see where someone might say something, they might commit a microaggression, and they'll say, that's not really what I meant, so I don't understand why you're so offended by it. But we always also understand that communication is two ways, right? It's a two-step process. It's what the communicator intended, and it's what the receiver received. And so I always let people know you don't get the opportunity to tell someone whether or not they should be offended. So when we're looking at this pre-contemplation, if I am going to stay in there and say, I don't have a problem, I'm not done with that, that's where we're at. And we know that we see these same things with our clients, right? So we use these same tools with our clients, but also look at them for ourselves. But if I start to understand that a person was offended by my statement and I start to see something was wrong with it, then I enter into contemplation phase. I may not totally agree with the offense taken, but I can see how it has impacted the person. Now, if I want to move into determination, I'm going to start to realize and I'm going to agree, you know what? There is something wrong. There's something wrong here. And I want to make a change. So now I'm going to start to plan my work. Maybe I need to find an accountability partner. Maybe I need someone I can talk to say, you know what? I said these things that I didn't understand it. What does it mean? Maybe that's something I need to do, but that's part of my determination because I'm planning what I want to do. And from there, I can move into the action phase. The action phase says, I am for real. I am going to change me. I plan the work. Now I'm working my plan. So maybe now I'm going to start meeting with my accountability partner and we're going to start discussing any of the struggles that myself or both of us are experiencing. Action. No, I said action. Maintenance says, you know what? My plan is working and I've made some changes, but I want to continue to make some changes. Relapse is normal. It's always there. It's my natural progression in the change cycle. But my question is, do I stay there? Or do I move out of relapse? And how do I do that? So as I'm looking at this process of change, I want you to think about where you are. Where are you at in the process? Because that's really what's going to start your journey in cultural humility. If you're still in pre-contemplation, there's nothing that I could say or do to force someone to move along the continuum. And also, you think about this, when we work with clients, if they're in pre-contemplation, we can't do anything to change them either. We can be a catalyst for change, but we can't force someone to change because the only person that we can change is ourselves. So as I am moving into my maintenance and I'm working my plan, I am beginning my cultural humility journey. So cultural humility, some ask me, what's the difference between cultural competence and cultural humility? It's just a buzzword now if you hear it, because you hear it all over now. But I will say cultural humility came about in the literature back in the 90s. It's not widely used, but the places that it has been widely used, and I will say in literature is nursing. Nursing is at the forefront of cultural humility in terms of their research and literature. I've seen it written across in education, in business, and I've seen it in multiple places. But in the human service or social service field, the research has been pretty minimal. But I think that's because we always focus on cultural competency. What's the difference between cultural competency and cultural humility? So with cultural competency, we can see that actually, let me talk about there's some similarities too, though. But cultural competence and cultural humility both seek to help one become a better clinician or person. That is the ultimate goal of both of them. But the method of doing it is what differs. So both are looking to reduce inequalities through developing cultural awareness and gaining cultural knowledge. But cultural competence has often seen as an acquisition of knowledge. Most of you have learned this in some sort of education arena. And typically what happens is we read some information in a text or we read some information in an article, but we tend to walk away with this as if this is gold. This is the only thing that we look at. So as I see this, I always go back to that acquisition of knowledge is sometimes what limits us when we talk about competency. Because when some people see the word competency, it denotes a finality. But when I look at this here, you see develop a cultural awareness and gain cultural knowledge are still requirements of cultural competency. I often see when someone talks about cultural competency, they'll say, you know, I took the class, I did 30 minutes of training, I'm good. I don't need any more trainings, workshops, webinars, because I know how to work with, and you can insert whatever term you want, whether it's a race, a gender, anything, you can insert all of that in there because that's what people will say. But the problem is we don't end here, right? Because if you look at the actual term definition of cultural competence, it does talk about it should be lifelong. But unfortunately, it seems like there's a finality in it. So cultural humility says, yes, I'm still going to develop my cultural awareness. It says I am going to gain cultural knowledge. But then the additional pieces to that is it's going to now talk about individual and institutional accountability. When I hear people say we're going to change the system, that's what we need to work on is changing the system. And the first thing that comes to my mind is we are the system. The system is made up of people. We are the people. We are the change that we need. So we don't need to just say like the system has to change. We got to change the thoughts and behaviors of the people who are running the system. And that's where cultural humility starts to come into place. The cultural humility, it is divided into individual and institutional accountability. Under individual accountability, we're talking about this is a lifelong journey. It's not a sprint. We will not complete this in this 30-minute presentation or an hour session. It is something that requires that we do continuous work, and it's an individual journey that we do on ourselves. We need to recognize who we are, how our values and beliefs have influenced our lives and have created some bias. So sometimes someone say, I'm not biased. We're all biased because that's who we are. In our human nature, we are biased individuals. And bias can be used that can be a positive piece. It can be helpful. You know, there's that intuition piece where there's the bias there, but there's also some bias that we hold against others that may be rooted in some of our own beliefs and values, whether it's religious, political, that impacts how we work with others though. So we need to take some time and learn about ourselves. That's in critical self-reflection and self-critique. Take a deep examination of who you are. Because while we're learning about ourselves, we're still learning about another person, but we also need to reflect on how I come in and how I impact who I work with. When I do private practice work, one of the biggest things I always keep in mind is, okay, this is my beliefs, here's their beliefs. We all come with the same thing, right? I come with my beliefs, they come with their beliefs. But the issue is when our beliefs start to clash, where do we go with this? And so sometimes we don't separate that, but we have to separate that because their beliefs are their beliefs, and that's not what they're there for. They're not there for you to tell them how to live their life, but let's help you live a better life. So this requires us to be open. If we want to be critical, so use critical self-reflection, critical self-critique, it requires us to be open. It requires us to have some sense of self-awareness. It requires us to be egoless. And then we also need to have supportive interactions as we work through this. The last piece of the individual accountability is recognizing and changing power imbalances. If you want to challenge power, you have to give space so that we can share the power. Because typically when we meet with clients, they already know that that there's a power dynamic between us. They know that already. But I don't need to reinforce that to them, right? I don't need to sit in front of them and tell them, well, I know better, because I don't. We all have problems. It's just that people deal differently. People cope differently. So what do I need to do? I need to shift from being the expert to being a learner. When we talk about client centered, I want to allow the client to tell me what's important to them. And then I want to learn from the community. I don't want to assume that I know everything and that I'm all powerful, because that really takes away from the work that I'm doing with someone. I often ask questions of my clients, and sometimes they look at me like I'm crazy. And I say, look, I just want to know, what is it? What does it mean? I see a lot of teens, and my teens, they say, they give you this language and some of these terminologies and different things. I don't really know what you're saying, but I want to know. And so they laugh at me, but they'll tell me. And then they'll tell me that I'm old school and all this other stuff. And I say, it's fine. I'll take it. I'm okay with that. But it's definitely something, though, giving some power back. Because when they came to us, we know that there was a loss of power. There's a loss of control when they come to us. We know that. So when we talk about institutional accountability, this is where we talk about the system, right? So we need to be holding our system, our institutions accountable for what's happening. But holding them accountable means starting with us, right? So if I have all these issues and all this bias and all these problems, and then I come up and meet with a client, then we can't say, oh, it's definitely the system. No, it's me. I got the problem. So I really need to start to challenge that structure. What is in that structure that's happening, that's allowing this to continue? When you think about structural racism, even in that sense, what is underneath that's allowing these pieces to continue? Because typically we only see behaviors, but what's underneath? Why is it set up this way? What policies are in place that perpetuate bias? We have to think about that in terms of the institution and then hold it accountable. But remember, again, who's in the institution? It's us. Your agencies or your practices. What's in there that may perpetuate bias? Because typically it is built in the work that we do. So we have to push past this. We need to move forward. And when we think about bias and cultural humility, there's really no room in the work that we do with our clients. Right? I tell my students this all the time. This is not saying you sat in here and I'm bias free, I'm good, I'm culturally humble, and I am perfectly okay. I'm not saying that, but there's this journey that we have to always be on the lookout, always checking ourselves, because that's where we start to run into the issues when we don't check ourselves. But it's easier to point to somebody else. It's easier to say, well, so-and-so needs to look at what they're doing. We are also doing something that may be problematic too. When I talk about cultural humility, when I think about this cultural humility piece and what policies are in place and what do we do with this? How do we really work through this? Because that's what I find in the literature that's lacking, right? A lot of people will talk about okay, you got cultural humility. We got cultural humility. So now what? What do we need to do with it? And that's where we find that. I go through social work journals and I've looked in psychology journals and different pieces, and it always comes back to what is it that's happening? What do we need to do to make these changes? So if I go back to our bias information and begin this journey with you, I want to just briefly talk to you about the 4 R's of cultural humility. So this was my struggle when I did this, and I did my dissertation work on this as well. And this was my struggle. It's like, what do I do with this? Where do I go with this? And so everyone wants to be culturally humble, but there's not a step-by-step procedure in doing it. So I was sitting at my desk one day and I said, I got it. So I wrote these down. So the first thing with the R's is I'm going to recognize bias. I'm going to recognize my bias. I'm going to time out from talking about everybody else's bias. I want to recognize my bias. What is it that I have? What do I hold? And this is really where you got to do that deep examination of yourself. whether it's your religious beliefs, your political beliefs, your family upbringing. What bias do I hold? What were my experiences? What have I experienced working with other people or just interacting with others that have impacted me? Then I need to reflect on that. What are the root causes of this? If there's something that happened to you that could be something that was growing up when you were younger. I was a military brat, and we moved every 3 or 4 years. And when I would come, when I first moved back to the US, because I did live most of my school age years in Germany. And when I first came back to the US and we came to our new duty station, I had never experienced the racism that I experienced when I came to the new duty station. And so what did that do? That started to set up this bias in me when I had to work with certain people or interact with certain people because of my experiences. But it took me a moment, or I want to say a moment, we could say a moment, but it took me a while to realize what was the root cause of why I treated people the way I treated them, or why did I feel a certain way with people? Because I needed to reflect on that. And then I needed to regroup. So when I regrouped, I had to figure out, how do I deal with unpacking this bias? Because it's not comfortable, right? It's not easy. It's not easy to go back to family history. It's not easy to go back through some of the beliefs that's going on, but I need to really regroup and think about, how do I unpack this? What do I need to do? So for me, I had to start with looking at what was the situations that led up to my feelings. And I had to resolve those situations. And whether it's reflecting on it, whether it's taking action on it, I had to do something, because if not, then I would continue with the same bias. But I also recognize that that bias started to impact how I work with other people, because that all happened when I was in high school. So then when I moved into college and started working full time and things like that, then I started to then I started to see the bias come out from myself. Also, we grew up a very religious family, and a lot of the things that I learned, they were very biased, and I had to really unpack that. And so unpacking that, I did share some things with my family, and it wasn't always good. Everybody didn't always agree, and I know there were some points me and my sister would have some pointed discussions on some things, and then eventually she was like, "You know what? You're right." I said, "Who are we? Who are we to say this? Who are we to judge? Who are we to do this?" And so that's where I started to regroup this, right? Then I started to react. So there were no more calls to action, because that's what I always hear. It's a call to action, call to action, call. Okay, time out for call to action. Now it's time to take action. We can't keep saying let's sit down and talk about it. No, let's start doing something. And so it's, what steps are you going to take to better yourself? What can you do? Because cultural humility always goes back to self. What can you do to make yourself better? And so in my journey, and I will tell you, my journey is not complete. Every day I wake up and I check myself for my bias. I do it every day. I will tell you that. But in doing this, what do I have to do to make myself better? So in studying cultural humility, in writing about cultural humility, in teaching cultural humility, I had to actually be culturally, start using cultural humility, right? You can't just say something and then tell someone opposite. Like my parents used to say, do as I say, not as I do. Well, that is an oxymoron. That doesn't make any sense. Like, I need to be doing what I'm saying, everyone else should be doing too. So those are some of the steps I took to make myself better. But it came back to the education piece. I had to educate myself and then move forward. And I love Maya Angelou quotes. And one of the quotes she said is, when you know better, you do better. And so even in my reaction, when I take the time to know what steps that I need to make me do better, then I also can share that with others who are saying that I want to take this journey too. The journey is just not just for people in human service field. It is for everybody. And that's one of the things that always it's interesting to me, but people always say, oh, that's just for social work. No, it's not. You interact with people on a daily basis, every day. Every day we interact with someone. I know right now the whole COVID has us a little bit, reserved, and people are a little bit kind of trapped in their house or something like that. But I go to the store, even with my mask on, I still smile. I know they can't see it, but I know you can see my eyes move a little different, but I still smile. I still talk to people, because that's what we do. We interact with people. We're social human beings. That's what we do. So our work that we do, it requires us to connect with people and to help facilitate a change. And our time is now. I mean, if you think about what's happening in our society right now and how things are impacting clients that we work with, whether it is political impacts, whether there are economical impacts. I mean, we can see large increases of substance use at this time because of what's happening right now with unemployment and different things. We can see all these things. The time is now for the change because we can't really walk up to someone and say, well, just because you lost your unemployment, I mean, just because you lost employment, then you shouldn't be dealing like you should be better. You be better, be better. They can't be better. People can't. And again, we are all in the same situation. Anybody can have a situation where they fall and then they're needing services from someone. Anyone could fall into that. So another quote that Maya Angelou says, and I love it because it really, really relates to us and whether we're beginning this work in cultural humility or we're continuing this journey, is people will forget what you said, people will forget what you did, but they will never forget how you made them feel. And that's something that I continually impress upon myself. When I worked in Juvenile Justice Commission in the jail, I worked in the prison with male residents is who I was primarily with, but I did also work with the female residents. And when I would work with them, I mean, a lot of my children, they were gang members, right? They were young. My youngest child was about 13, and I had some that went up to about 22 or so. But I had one. He was a very high-ranking official in the Bloods, and at 15 years old, that means he did some stuff. He did some stuff to get to that point. And so as I talked to him, I first talked to him, he didn't want to really have any interactions with me. He just kind of was like, whatever, whatever. And so finally we met like a one-on-one again. And I just, asked him like, how you doing? What's going on? And just talking about his education and things like that. And I asked him, what do he see himself doing in 5 years? And this child told me, he looked at me first and he said, that's what you really want to know that? You want to know that, Miss B? And I said, absolutely. What do you see yourself doing? And so he tells me, I want to open a daycare center. And so I know y'all see, because I can't see y'all face. So, but I know some faces changed, right? Because I just told you he's a high-ranking official in the Bloods, and he said he wants to open a daycare center. Because I'm gonna tell you my own bias. The first thing I thought was, what you talking about? What you trying to get street soldiers? Like I'm going, like that's my whole thought, right? Because I'm biased. But as I started talking to him more, I said, tell me more. Tell me more about what you want to do. And so he told me, you know what, Miss B, I want to have a place where kids can come after school and have food to eat, where they can sit and be relaxed and do their homework in a safe location. And then he starts telling me bits of his story. He said, it wasn't a day that I didn't come home that my mother was not laid out with a needle stuck out of her arm. There wasn't days I didn't come home, and this is his language, that fiends were in the house with needles in their arms passed out. Said by the age of 12, I started selling drugs to make sure that my siblings had food. By 13, I lived in my own hotel room so that I made sure my siblings had food. I brought them food. I lived in my own hotel room. I lived on my own by 13. By 15, this young man was incarcerated for an armed robbery. And so as I talked to him, this was just, it really hit me because this whole piece of cultural humility says, if I wouldn't have recognized my own bias, I could have did some damage to him. And so just in talking to him, and then now he wants to talk to me. Like if I saw him in the hallway, he said, Miss B, are we meeting this week? I said, oh, okay, yeah, we'll talk, we'll talk. And so it was very moving, but because someone showed that they cared. Someone gave power, shared power with him. And so in that, when I proceeded, and then I was doing a lot of training throughout the state and doing these things. And as I started proceeding in my job, and he moved on um, to another facility, and in moving to the next facility, he says to me, you know what, I called the other facility and told them that he was coming and he just needs somebody to talk to him. And so the social worker would allow him to call me. He would call my desk phone and he would leave me a message. And he said, Miss B, I just want to say hi and just see how you're doing. But that humility, that piece of it, it just showed that he never forgot how I made him feel. And that's what I want to impress upon you because the work that we do is so important and it's so necessary. And we have to do it from an angle that we are helping the person that we're working with and not hurting them. So I know my time is up. I was monitoring it. I think I had till 1:43. Um, and I just want to say I thank you for your time. And I'm going to turn this back over to Diana.
Thank you, Dr. Bembry. So very moving and powerful, and you can tell by a lot of the comments in the chat box. So thank you for encouraging us to really look into cultural humility and integrating that in practice. And so these sessions the contents have been very provider focused, and we're very conscious of the fact that we are suggesting tools and strategies for you to incorporate and to look at yourselves and as outside of the professional cap that you wear, but also look at your professional practices. So it's also important to understand that for you to do the work and keep moving forward and become even more effective, particularly when we're talking about addressing the inequities for racial and ethnic communities that we serve, it's important for us to have an environment that supports us in service delivery and when we are doing this. And that's important for our clients and patients to understand that the setting is conducive for them, but it's also important that providers have that supportive environment and when they need it. So I wanted to go through the National Culturally and Linguistically Appropriate Services class standards. We have a lot of this information as part of our curriculum. So this kind of brings back a little bit of what Dr. Bembry was speaking and really reflects some of the information and data I had shared with you all right from the beginning. And so some of the literature, and this comes from a report from the Cultural Competence in Healthcare out of Georgetown University, as the population at risk of chronic conditions become increasingly diverse, more attention to linguistic and cultural barriers to care will be necessary. For anyone that has been attending these sessions right from the beginning, there was a slide that I had provided that I've showed the projection of all the cultural groups, how it's expected that the populations will increase. And if there are challenges now, we need to become even more adept, even more skilled in terms of addressing unique needs for our diverse communities. So this is something that, some bulleted points coming out of the report. Native Americans report more frequent episodes of poor treatment compared to other groups. The Black African American or Native American, Hispanic, Latinx groups are more likely to die of diabetes than the larger dominant population. The racist experiences have also been noted a lot of times to be the barriers to lower service satisfaction and the access of conventional health services. So a lot of times we don't always consider that a lot of our folks might get to us, but have not always come to our care, our specialty services. Many times what they'll do is they'll go to whatever resource is the most comfortable, and they will try to address their issues in one place as opposed to going to another place that might provide specialty care. A lot of times it's either the quality care is not available, or the specialty care is not available itself. So it's a host or a myriad of different things. But culture impacts health outcomes, and as well as the health-seeking behavior. It also has to do with their priorities in their world. You know, if taking the children to get their checkups or get needed vaccination is more important, it's likely more important than them getting their selves taken care of if they're sick, in light of perhaps showing up at the job that they might lose if they don't attend. So you have to consider social determinants and other issues that have a lot to do with white folks' behavior or don't seek behavior. So culture impacts also their responses to medical interventions, affordability of care, insured and not insured, or specific criteria or limited parameters of insurances for specific conditions. So the title, back like Dr. Bembry did, to implicit bias and how it correlates with health disparities. We also seen, when we've seen your examples, we have the presenters who have talked about how what it looks like in different settings. So this comes from a report. This is one of many. And it says white male physicians were likely to prescribe pain medication, were less likely to prescribe pain medication to Black patients than to white patients. Sometimes the physicians assume that the lower income patients or Black patients are less intelligent. are more likely to engage in risky behaviors and less likely to adhere to medical advice. We've seen that women presenting with cardiac disease, showing symptoms of cardiac disease, are significantly less likely than men to receive a diagnosis or referral or treatment due to a misdiagnosis of stress and anxiety. So when we consider these issues through a cultural lens, it really encourages us to take extra steps to look closer. So we've been talking about it, and I know some of the folks in the chat box have brought this up, but we have presented on some bias reducing strategies that can help. So biases, as Dr. Bembry said it, and as we've been saying it, we all have them. We all have them. If we didn't have bias inside of us, we wouldn't have a preference for a favorite color, wouldn't have a preference for a favorite type of car, favorite type of music. It's the other side of that same coin that works out in a certain way, depending on the influencing factors in our world. So since we have it, since we understand that, there's things we can do about it. So in our humanness, and we can build on our awareness. So this is a few activities you can engage in. So we've spelled out implicit, and these are the strategies that can be undertaken. So introspection, the I for introspection, explore and identify your own prejudices. And when Dr. Bembry was speaking to that in terms of in the context of culture and humility, some of you were in the chat box and asking about what different things can you do. And someone did suggest or asked about the implicit association test. That is one of many different strategies you can engage in, different measures that you can access to be able to try to gauge your own level of implicit or hidden or unconscious bias. There's other means of self-analysis, there's other scales and measures out there. You can consider who are the folks you have always engaged with? Who did you used to date before you got married, if you did get married, before you partnered for a long time with someone? Where are the places you tend to engage, to frequent? Where would you live? There's a host of different resources out there that will speak to that, and we can give you some of that a little bit later. M is for mindfulness. The idea here is that since you're more likely to give into your biases when you're under pressure, and I dare say that absolutely none of you in any one of the disciplines are not ever not under pressure, and particularly in our current environment. And so, practice ways to reduce stress and increase mindfulness, being present, being more conscious and intentional in how you process information, in looking to elicit information, in making decisions, consciously, intentionally, as opposed to routinely, because we all can get very routinized, if you will. So focus on being present in the moment. So breathing and some mindfulness, other activities you can engage in. Perspective taking has to do with considering experiences from the point of view of the other person, who is typically stereotyped. You can do this by reading or watching content that discusses those experiences, or directly interacting with folks from the other communities that you might find challenging. Learn to slow down before interacting with people from certain groups, particularly if you start to build awareness and you are aware that you have certain reactions around certain folks. Then be mindful and pause and reflect to reduce potential reactions that can have very negative consequences or effects. Consider positive examples of people that are being stereotyped instead of the stereotypical association that tends to come up. Challenge that, So individuation, evaluate people based on their personal characteristics instead of the associated stereotypical references because of the membership that they identify, membership to a particular group or who they identify with. So you can connect with folks, especially when it comes to culturally informed practice. It doesn't necessarily have to play out that that a Black African American provider is the best match for a Black African American male client or patient. It can be. There are many places where there are limitations in terms of having providers that actually reflect the communities that are served. So you want to find different connections of interests. And that can help you in individuation. So it gets you past what any kind of bias you have, but it helps you to actually connect with them as a human being, like we all are. So check your messaging also. So we always talk about language here, and I'm going to focus a little bit more on that in a minute. But check your languaging. What we're used to saying, and be conscious and intentional when we say certain things. Well, last week we were talking about microaggressions. Sometimes we say things where, oh, we think we have a really light heart, when we say a joke, but then it can be very offensive. So things like we don't see color. These are statements that are not welcomed and not embraced. You want to embrace the multiculturalism. You want to celebrate differences. Institutionalized fairness, promote procedural change in the organization level, move toward a more socially accountable healthcare or behavioral healthcare system with the goal of health equity, which is in its entirety what class is about. And take two, it has to do with practice culture humility that Dr. Bembry was just speaking to. The lifelong process of critical reflection to readdress the power imbalances between clinician and patient, between provider and client. So the culturally and linguistically appropriate services standards for health and healthcare, and we're speaking specifically to the behavioral health disciplines, really speaks to what the Department of Health and Human Services Office of Minority Health developed back initially in 2000. And so the class standards are intended to advance health equity, to improve quality of care, help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations. So it's for both. So to implement culturally and linguistically appropriate services. So they were developed by the Office of Minority Health and in 2000, but after the medicine's publication of Unequal Treatment was published and came out in 2003, the standards were updated and they reflect the enormous growth in the field of cultural and linguistically competent and linguistic competency and skill sets and in the fields, in the behavioral health fields, and the ongoing and increasing diversity of the country's population. And so this is what we're speaking to today. So if you haven't seen this before, and it's surprising to me, I've presented on this in other places outside of New York, and for some reason, folks have not heard of the Enhanced National Class Standards. It could be because it's not a standardized process within or across the disciplines, which is why we're really pushing, because we are not, we're just seeing more and more of the inequitable outcomes for our diverse communities. So these class standards are divided into 4 themes. There's the principal standard, which is an overall arching theme. It actually includes the components of the broken down, the other 3 themes, which breaks down the principal standard more specifically, better to understand and explore to be able to apply. So the first standard speaks to providing effective, equitable, understandable, and respectful quality of care services that are responsive to diverse cultural, health, and belief practices and preferred language, and in health literacy and other communication needs. So one of the things we tend to do is we look at the standards that were created by OMH, and then we want to help organizations to understand, participants and providers in their settings understand how they can apply these concepts. And so these parameters are help to build capacity within any setting or organization, will help going through a question process, going through an implementation process that includes some considerations, will help you better implement this within your setting. So it's not supposed to look the same for everyone or in every organization, but you want to really tailor it to the communities that you're serving. So so one of the first things when it comes to anything culture is what cultural groups, who are you seeing in your communities? Who are you servicing? What are the issues or the characteristically common trends that you tend to see? What does commonly present in your practice? So what questions or concerns would you have about navigating cultural language barriers for persons of specific racial, ethnic, linguistic minorities. So, and let's not exclude the folks with disabilities, folks with gender identity, um, uh, gender non-binary, non-binary gender or sexual orientations. And we want to be able to not just look at the communities, but take a close look. There was back in the day when we were doing cultural competency trainings, we were always talking about assessment, look at the demographics, and be able to tailor your services accordingly. What we're encouraging you today is enhance that process, look closer. Not everyone is Hispanic only, and not everyone is Black, or not everyone is American Indian. You have some very specific groups. You have Haitians, you have African Americans, you have folks from Dominican Republic, you have folks from Bolivia, you have a lot of different tribal nations. In the Asian populations, you have the Hmong, you have other communities. Understand who your community is. How would you do that? You would want to do an assessment. Before you can move forward, you have to know what you're dealing with first. So this process is helpful for us as providers as well as organization. So the organization and patient client, and from an organizational perspective, you want to run an assessment and you want to be able to understand what's there. Everything that you're doing is not bad. Everything that you're doing does not need improvement, but there are some areas that you can for certainly build upon that will work and align better with other service delivery structures that you have. So you have to be able to identify that, to correlate that with outcomes for racial and ethnic communities that you serve. So, and then the self-assessment, and Dr. Bembry was talking about that quite a bit about, the patient client or the clinician and the patient, that the dynamics between that association, that interaction. You want to be able to assess how you see what you know and how you elicit information, and then do your own self retrospect. So the standard one, assess for agency capacity to provide culturally supportive environments at various levels. You want to identify the cultural patterns and behaviors of diverse communities that can help inform what services are needed and how to best deliver them. You want to be able to gather data, include the surveys, the consumer surveys of effectively delivered services, but also seek to connect with consumers or constituents that fell out of care, and find out and see if you can learn what is it that didn't work. Because it's really great to connect with someone who is very happy with your services, but that's not as telling as being able to access folks who have not gotten a lot out of your service. That can be so informative to your to you building capacity within your organization. The other theme is governance, leadership, and workforce. And so in terms of advancing and sustaining organizational governance and leadership that provides class and health equity through policy and practices and allocated resources. And these I cannot change because this is what OMH says themselves, but this is what makes you want to think about what does the organization have, say, a culturally informed mission statement. When it says recruit and promote support culturally and linguistically diverse governance, leadership, and workforce that are responsive to the population or service area, how is that done? And how often is that done? Educate and train the leadership, governance, and workforce in class and include that in policies and practices on an ongoing basis. This is more than just checking off a cultural competency class and say, okay, I got my hours so I can I can re-credential or I can keep my license. This is about implementation. Knowledge is nothing if you don't apply it. Communication and language, and I'm not really going to try to rush through too much because I don't want to speak so fast that you don't understand, and I promise that we will stay on to be able to address some of your questions and comments. So with the other theme about the second theme about communication and language, you want to think, well, this is one of the first things that tend to come up in terms of challenges with working with diverse communities. So language assistance to individuals who have limited English proficiency and other communication needs at no cost to them and facilitate timely access to all healthcare services. And so here's the interesting thing. There are a lot of folks, a lot of our patients and clients are not aware that they can actually request that that resource through you, and be able to have clear, communication, and be able to understand, what the process of recovery and wellness that you are helping them with, no matter what the field, whether you're supporting their recovery process from addiction, or whether you're talking about a mental health issue. Um, how do you convey that with with diverse communities? It's not always about just a specific language. It's about the context of how language is used. So just because you know the language of one particular community doesn't mean that the dialect is the same and the understanding and comprehension is the same. So these are issues to this is how these are issues to look at. This is why I encourage that folks have to take a closer look than what we have always encouraged before, to um, inform individuals of the availability of language assistance services, and clearly, and and service plans should have always been uh, developed in partnership with your client or patient, and also within their language. So ensure that the competence of individuals providing the language assistance recognizing the use of untrained individuals and minors. So you want the environment to be able to provide these resources. Using family members is not the best choice for interpretation. This is if we're talking about this can create a biased communication and misinformation, and this is what we want to try to avoid. So provide easy to understand materials, literature, resources that they can that they can read and understand even more, and provide more information to what you're saying to them in their language. So ensure that you know who the communities you serve. Again, the assessment is so key. And then also materials are in signage language. For instance, sometimes if some of the communities, you have to put some things in Braille, if you have to use some electronic programs to better communicate some information. These slides that we will give you, they also have a lot to do with us being 508 compliant. We want to make sure we are culturally appropriate for all folks. So we have folks with different disabilities. We want to make sure that you can read, that you can hear it, you can read it, that you can understand it. So we do the best we can integrating that concept in our settings with our clients. So engagement, continuous improvement, and accountability is the last theme. So it's speaking to how organization can establish culturally and linguistically appropriate the concepts and their policies and protocols, and the management accountability. And so this is for addressing and running all planning operations. To conduct the ongoing assessments. And I remember Dr. Bembry and I were talking about different types of evaluations that exist for when you initially have a new program, to monitor, to assess what your current service delivery looks like, who's it working with, who's it not working with, or process evaluations when you have expected outcomes and you can compare it and have a baseline and compare to what you might be the outcomes a few months later. Extremely important. So also collect and maintain accurate and reliable demographic data to monitor and evaluate the impact of class on health equity and outcomes. After you integrate a lot of these strategies, when you come together and you put all this effort in, you want to be able to see efficacy. You want to be able to see that the outcomes have improved. And so, on this, conduct regular assessment of community health assets, understand who your community partners can be, what are the resources in your catchment area, partner with with other community organizations, do stakeholder meetings. There is shared goals that you have with other community organizations that we can all kind of band together. We can work together to understand what are the community needs and how we can help each other to build that equity with diverse communities. to create conflict and grievance resolution processes. And that is for the organization. Ensure that there is a way that if there is a situation, that it can be reported, that it can be identified, addressed, prevented, and resolve the conflicts. There has to be a way. There's certain things that you can do anonymously at first, but certainly have the protocols in place for providers and for clients or patients to be able to have an opportunity to address a potential in a situation that potentially seemed negative for them and could have been very targeted. You want to have that in place. This is also telling. This is really builds a lot of the credibility for organizations who are willing to do this so they can improve on their services and really provide quality care. So communicate the organization's progress in implementing and sustaining class to all stakeholders, constituents, and general public. And a lot of us do have these periodic community advisory board meetings and such, and this is the whole point of that. So we can all stay helping each other and focus on helping the community. So I wanted to end with this, and then class matters. Health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And this is what we've been talking about the whole time. And you folks are the ones who are making the difference. We're just suggesting that there are other tools and strategies that you can implement to be able to continue to make that difference and really improve upon that, because our communities right now are such in need of our services. So I just want to share with you all, I just want to let you know, I want to thank Dr. Bembry first. Thank you so much for being here with me. I really enjoyed your presentation. I love everything that you've given to our participants and myself, I'll say. We never learn enough. And so I'm always delighted with that. But I also wanted to thank all of you who are on attendance of this webinar. Thank you so much. It's been another wonderful session.